Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this, can I say it, snowy spring morning in late April. But we're happy to be here with you, and I'm joined today by some really great guests. Of course, we always have Hawkeye, Medical Director of Infection Prevention Control. Welcome back, Hawk.
Hi.
Actually, why should I say welcome back to him?
Right.
He's always here. It's like my right hand right here. We're also joined today by Dr. Joseph Mcgurk, the Division Director for Hematologic Malignancies and Cellular Therapeutics. Say that really fast.
You did great.
Not bad. We just say HMCT because it's so much easier. And a good friend of mine, Dr. Mcgurk, has done an amazing job helping us continue the build of a bone marrow transplant program, now our CAR T therapy program. I mean, there are so many cool things that he's involved in. We're delighted to have you with us today to help us with this conversation. And Dr. Ala Abdullah, the Director of Plasma Cell Disorders. Thank you for joining us, Dr. Abdullah. We're delighted to have you here today, too, because you got some pretty cool news here about that we're going to launch in just a few minutes. Yeah, both physicians are here with an update on the impact of COVID-19 on their patient population and progress on CAR T therapy and multiple myeloma and some connections between all those statements. So this is going to be fun. We may ask a question or two about the Johnson & Johnson vaccine. We had a great question delivered to us yesterday. We want to follow up with you guys because I thought y'all would be better equipped to answer it than we were. But before we dive into some of that, Hawkeye, how are we doing?
Numbers, holding steady. 13 active infections, 7 though in the ICU, so over half in the ICU. 3 are on the ventilator as well. 8 in the recovery period, so 21 total patients, which overall total is still good, but again, quite a few people in the ICU. And then Hayes has 3 active infections and 1 in that recovery period, so 4 total.
And it feels like we're kind of bumping along at the same number now. We've been there for a while, that this is our current normal. I looked at the 7-day average in Kansas City. I'm not completely convinced to what that means anymore because people aren't getting tested as often. But we got down to 94, I think, as a rolling 7-day average. We're up to 130, 160, and starting to go up again. And a slow, not like what we've seen in Michigan and some other states, but still going up, and something we have to keep an eye on.
Yeah, exactly.
So, and I'm trying to think if I read any major new news last night. The big thing that I came across this morning was more information about the multi-system inflammatory syndrome in children and neurological complications from that. So really important. I know we're going to get our Children's Mercy folks back on to talk more about that, but that's becoming more important, and yet one more reason to make sure our kids are protected, especially as we reopen schools, try to go full throttle on things. Got to make sure we don't endanger lives at the same time. Yeah,
and still on that point, we know that Michigan is suffering hard right now as a state, but their pediatric hospitals, they have seen more admissions for pediatrics than they have during this whole pandemic. So they are looking at and investigating, I think, over 300 outbreaks related to schools, whether that's in classroom or sports events or other things just outside of the schools, but linked to the school in some way. So, it's not clear really that any of the variants cause worse disease. It's just that we are now having just more spread of the disease.
And Amanda Cackler sent us some information last night. Do you have that at your fingertips? A visit around, because someone asked the question, are we getting younger? And the answer is we are getting a little younger in some of our inpatients. Do you want to cover some of the things that she said?
So of our currently admitted patients, we have numbers are a little bit down. They had 6 ICU patients at that time, but young is 40. So 40 to 74. So still not that 80s and 90s age range for the top, but certainly changed. 40 is young. We have also patient as old as 34, as young as 34, just on the regular floor as well. So one seems to be maybe vaccine breakthrough patient who had received 2 doses of Pfizer vaccine and was symptomatic as well. So.
Yeah, so again, it's a 95% protection, not 100% protection, and still is really good. The other question that we were asked yesterday, and I'm going to just turn to Dr. Mcgurk, and then we're going to see if there's any reporter questions, but and then we'll come back to y'all. But one of the questions that popped up is, do you think that there are specific disease categories with the recent information that the J&J vaccine or the AstraZeneca vaccine represents something we call heparin-induced thrombocytopenia, like now we're calling it vaccine-induced thrombocytopenia. But do you think there are certain diseases, especially blood and bone marrow diseases, that would predispose you to complications from the J&J or the AstraZeneca vaccine?
Well, it's a great question, Dr. Stites. The data so far represent young females, as you know, and it's a 1 in a million chance. It's an extraordinarily rare event. We're keeping our eyes out for it, and a very significant percentage of our patients with blood cancers and other blood disorders have been vaccinated already. And those who have not yet, we're pushing hard to make sure we get everybody covered. And we haven't seen any such events in our population of patients so far. But again, we're not letting our guard down. We're keeping our eyes out on this.
Yeah, so it's a big deal, and we'll learn, as we say, we build and we learn as we fly the plane. So,
and I think one more thing,
please.
you talked about vaccine efficacy and the breakthrough. We understand there will be breakthrough, and that was seen in the trial. It's just your overall spectrum of disease and risk of getting to needing hospitalization, and of course death is significantly reduced. So that's the important thing, I think.
Yeah, that's where we vaccinate. All right, let's see if there are reporter questions out there this morning.
Good morning, Cody Holyoke.
Hey, Cody.
Channel 9.
Cody.
Hey, guys. The State Department is changing travel warnings and kind of ratcheting them up a bit because they say COVID-19 and the pandemic continues to pose unprecedented risks around the globe. And I'm just curious your thoughts on travel. I know we've seen Doc Hawk going around with the eye protection and the masks on planes, and everybody's starting to travel again. With that in mind, what should people be doing? And maybe just a refresher on the recommendations.
That's a great question. The CDC did say they're going to put 80% of the countries across the globe at a surveillance level, saying with the recommendation to do not travel. And it was all about COVID-19. It was an interesting change of events because they haven't been that strict thus far. But I think what they're really worried about, Hawk, is the variants about in different countries and bringing new types of not new types, but new variants back into the United States, and also just the risk of travel where there are varying degrees of immunization across the world, and some countries still fighting a significant surge.
Yeah, I mean, even, again, we had mentioned Israel yesterday. Israel today, again, also showed a significant reduction. They have over 80% of their vaccine-eligible population vaccinated, showed over significant reductions in hospitalizations, severity of disease, and death. However, also now they have also reduced their mask restrictions, so they've taken off in public outdoors. But they are concerned, and they are continuing to watch just because of that fact that you stated about the variants, things like that. They've identified a few cases of the variant first found in India there in their country as well. So I think, we really have to understand where are we traveling. Any travel that I've done, of course, and I would be reluctant to travel international, but any travel has been in the United States for domestic travel and things of that nature. So, but you have to understand and know how to protect yourself. And I think we've shown that. We've talked about that. Masking and eye protection, especially on things like in the airport or on the airplane, are going to be extremely important.
And I would just add, I think that, you've shown us the right way to travel. I have not traveled by flight. I'm planning to for Memorial Day. I haven't seen my sister in almost 2 years, and we're going to go out. She and her husband live in Oakland, California. We're going to fly out there and looking forward to that trip. But I'm going to follow the Hawkeye recipe. It's going to be wiping down my area, even though the CDC has said surface contamination is probably not an issue. But still, when I travel, I'm going to be contained in that one space for quite a while. Then I'm going to go ahead and wear a mask, and I'm going to wear my eye goggles. I'll have my glasses on, so yes, I'll have 6 sets of eyes, and I'll look great because, really, who cares? I'm on an airplane. But I think it's been demonstrated that through epidemiologic data that airplanes are relatively safe if you take the precautions you're supposed to take. And remembering that many of the studies were about COVID safety on planes were done with de-densified planes. So whether or not they're safe in a crowded plane is a different question. Now, I feel better because I've been vaccinated. I should have great immunity still from it. This is really the time, I think, to go. And overall, the numbers in the U.S. are a little lower. But I'm going to take all the right precautions, including wearing that mask in an airport, not going to eat while I'm on the plane, going to do the things I can to stay safe and therefore keep my family and everybody else safe around me. And I think you can do that. I think you just, again, you have to remember that the rules of infection control, yes, I'm about ready to say it, the rules of infection control travel with you wherever you go. And those rules haven't changed. Wash your hands, wear a mask, don't go out if you're sick, cough into your elbow, keep your distance. On a plane, it's harder to keep your distance. So you got to make sure you've done all the other things too. Plane design around airflow has changed significantly in the last few years, and especially even through the COVID pandemic, to have even stronger directional flow so that the airborne particles don't sit in the plane for as long and get between passengers and or do a better job of filtering. So we think that's better. Airports can still be a different matter. So again, you have to do all the things, all the rules of infection control, travel with you wherever you go. And we know if you follow the rules, based on our own experience right here at KU with our own staff who have taken care of now thousands of COVID patients without getting sick from our own patients. The rules of infection control, they work, they travel with you, and if you follow them, they can help keep you safe. So I think that's how I look at it.
And I think continuing to promote vaccination. Vaccination, it's not going to be an immediate effect. It will, lag 10 days or 2 weeks as far as showing a significant decrease. But it will happen, decrease in hospitalizations, severe disease, and death, of course. So.
Other questions out there?
Quick follow-up.
Please.
Dr. Hawkinson just mentioned Israel and outdoor mask requirements. There was an interesting article came out in The Atlantic almost suggesting that might be the first step to opening up, even as vaccinations increase. And I was curious your thoughts on that, because obviously indoor mask requirements are still going to be here for a while. But just maybe even lessening outdoor mask requirements.
Cody, I hope they are. I'm a little nervous. People are getting a little happy here and trying to move ahead, I think, of where the science is. And since they're saying, gosh, the numbers are down, vaccine, I'm a little worried about what some of the counties are going to start doing and some of the cities are going to start doing around masking. We're already seeing it in many states, right? We're removing our infection control policies. And but I like what Israel's doing. I like the approach. Let's get that a lot of people vaccinated. The U.S. is at about 50% of those who are eligible over the age of 18. About 50% have had one vaccine. So that means, let's presume most of those people get their second dose. So let's say 50% of people within a few weeks will have had some vaccination. That's a good number. It's not where we need to be. Many people are saying we're going to top out at 60 or 70%. And that's not where we need to be. We need to be at closer to 80 to 90% to really be safe. So what Israel is doing, though, is saying, hey, let's test it outside before we go inside. I think that makes complete sense.
Yeah, they still are doing it inside. It's just outdoors, even for non-exercise situations where they can do it. So certainly indoors, they are still doing it. But I think that's important to understand. And hopefully it is one thing closer. They have a collective culture. Our cultures are different here depending on what community you live in, where you live, what state, things of that nature. But it is all for the collective goal to keep everybody healthy. And it's not necessarily for the individual, but it's everybody around you so that we don't see those surges like have been going on in Michigan, which is devastating. And again, not only for adults, but we have seen a significant increase in their pediatric population that is being hospitalized as well. So,
other questions?
Hi, guys. It's Taylor, 41. Good morning.
Hi, Taylor.
Dr. Stites, you mentioned one there about travel still wiping down your seat, even though that's not necessarily what the CDC recommends any further. I wanted to ask you if we could get us up to date now as we head into summer on the cleaning procedures and protocols that we should be observing, so to speak, especially with schools having to figure out how much they're budgeting for all the hand sanitizer and all the wipe down stuff and all the extra cleaning stuff they're doing as they get ready for next school year with more kids coming back. What's the best practices and the most feasible practices moving forward on the cleaning stuff?
Yeah, that's a great question. So I'm going to wipe down my area because I'm a nervous Nelly, and I think there's a lot of reasons to wipe down your seats when you got onto a plane. One is COVID, and another is still influenza. It could still be out there, and lots of other viral things. So it's not just limited to COVID. But Hawkeye, I think that as far as schools, et cetera, services again appearing a little less of a concern. But man, hand sanitizer goes a long way for a lot of infections, not only COVID.
Yeah, and I'll have to look back, and I don't remember exactly if it was on the CDC website or if Dr. Fauci had talked about this, but you still need good cleaning practice. So routine cleaning practices, just normal household cleaners is good. There were a lot of people going around spraying things of that nature. But I think for desktops or eating surfaces, wherever that may be in the schools and things of that nature, you still need to do good routine cleaning practices, disinfecting surfaces, and that can be done with any real household or probably school or industrial cleaner that's available. But then I think, just as you said, the more important part of that aspect is the hand hygiene. And the hand hygiene we always talk about is number 2 or number 3 in those infection prevention pillars. So that is very important to continue to promote good hand hygiene.
All right, other questions? Dr. Mcgurk. Oh, man, I've been looking forward to this conversation. So how has the pandemic affected your cancer patients?
It's been incredibly impactful. I am preparing for this Saturday. We're doing a regional conference on stem cell transplant and leukemia patients, and I've reviewed over the last several weeks the world's literature and our own center data on the impact in patients with blood cancers, blood disorders, and stem cell transplant. And the mortality rates have been terrible. It's been devastating. And the primary driver behind that, reason for that, is despite the fact that we've been living these precautions of masking, social distancing, having the kids come home from school, for our stem cell transplant patients in particular, change their clothes then, take their baths, get those things into the laundry and such. Our patients have been contending with community respiratory viruses forever, for decades, and so these have been routine policies for our team. Despite all of those efforts, many of our patients have still acquired COVID, too many, and we've lost 7 of our transplant patients in complete remission afterwards. The world literature shows the mortality for hospitalized patients with blood cancers is in the 30 to 35% range, and the likelihood that they'll respond to a vaccine. We recommend vaccine for all of our patients universally, and we've had a high compliance rate. But despite that, they are expected not to have as robust of an immune response that's protective as the general population. Again, reinforcing the critical importance, as you and Dr. Hawkinson have been discussing this morning, of those other practices, infection control practices that will help protect these patients. So we jump up and down about these issues on a daily basis, but unfortunately it's been incredibly impactful. Making sure that the family members get vaccinated to help protect our patients has been a mainstay of keeping them safe as well.
Yeah, that makes sense. Dr. Abdullah, how about for you and your patients? What's been the biggest effect of the pandemic, and how have your folks
I echo what Dr. Mcgurk has said, especially with our population of patients. Generally in cancer patients, they're always immune compromised. Our blood cancer patients, specifically myeloma, not only they're immune compromised, they have other issues like comorbidities and elderly. And in addition to that, most of them are on treatment and require treatment that can cause their counts to drop down. We have seen, unfortunately, a higher number of cases, especially during the major waves that happen here in Kansas. Most of our patients have severe infection, and they also have a higher rate of being in the critical care, and as well higher rate of mortality. That was the major issues that really affected our populations in the myeloma specifically.
So, Dr. Abdullah, tell us a little bit, when you say to your folks, time to go and get a vaccination?
Immediately, I asked all the patients specifically that they have to get the vaccine. We just need to know the timing when they're going to get the vaccine, due to the fact that some of these patients, actually most of these patients, are on treatment. We try to avoid any type of drug interaction that can happen from these treatments. These treatments could be some antibodies or some intensive chemotherapy. So we try to actually hold these treatments and make sure the patient is healthy enough, to go and get the vaccine. So whenever the patient have the ability to get the vaccine, we encourage them. The stem cell transplant patients, I think they're a little bit unique. We wait maybe after 2 months to 3 months in order for them to get the vaccine, because maybe that's the best timing for their counts to recover.
Dr. Mcgurk, Mcgurk, what percentage of the patients do you think mount an immune response after vaccination?
It very much depends on where they are in their clinical course and what therapies they've received. Keep in mind the bone marrow and our blood, that is our immune system, and our patients develop cancers of those cells. And so our therapies are specifically targeted at the cells of the immune system, crippling the immune system. And so in our patients, if they're in the midst of receiving therapy, as Dr. Abdullah just described, or shortly after transplant, their likelihood of responding to a vaccine approaches zero. And we're actually running a study at the University of Kansas currently on 500 patients. We're looking at patients with blood cancers and solid tumors and their antibody response to vaccination or having been exposed to COVID previously. And in both of those settings, if they're in close proximity to recent therapy, their chance of responding is very low. In contrast, if patients are further out, beyond several months from their most recent treatment, for those patients that Dr. Abdullah cares for, and for our stem cell transplant patients, the likelihood increases predictably in those patients. But even with that, again, back to infection control, we can't rely on that. We don't know, we don't have the studies yet available on a routine basis to look at how that patient has responded other than antibody titers. Looking at the T cells is more problematic. So we assume that they still need that extra precaution and infection control measures to keep safe.
And do you foresee a time when your patients may need a third shot or a fourth shot to try and continue to boost their immune system? How do you think that's going to play out?
Yes, very much so. This is really an important question, and it's actually already our current practice in the field. Our patients receive multiple influenza vaccinations, for example, right before stem cell transplantation, at 100 days after transplantation, at 6 months after transplantation. That's not a general practice in the population, as you know, but it's to boost that immune response, and we have data to support that. So we don't know yet what that looks like for COVID vaccinations. However, we're in the process of studying it, and I would expect that they will need boosters down the line because of this incredible immunodeficiency that we induce with our therapies and that their cancers cause in the first place.
And I wonder if I could ask, and how have we seen safety in these people getting these multiple influenza vaccines?
It's been universally safe in every single patient we've vaccinated. We've had some patients with very mild symptoms the following day that give us a call, but we've not seen any adverse effects at all from vaccination, and we wouldn't expect to.
Yeah.
So I want to change the focus of the conversation to CAR T therapy now. And I'm going to ask first, in just a moment, I'm going to talk to Dr. Mcgurk about CAR T, and you're going to explain it to us on what it is, but in simple terms. And we're going to talk to Dr. Abdullah about the things that are going on in multiple myeloma, because there's some pretty remarkable stories coming out. So we also have a video that we're going to show of two patients getting their cells collected. So Dr. Mcgurk, tell us a little bit, what does this mean? What is CAR T therapy? What is CAR T therapy?
Absolutely. CAR T cell therapy is a chimeric antigen receptor modified therapy.
You got to tell us what that means, brother.
So what that means basically is we know that T cells control COVID, the COVID virus. They attack and kill virally infected cells.
Yep.
T cells also control cancers. And so when we get a cancer and it grows uncontrollably, our T cells were supposed to have stopped that from happening and prevented it in the first place. But the cancers are smart. They manipulate our immune system so that they can thrive and propagate, unfortunately. So as we've learned more about how those T cells function, or when they don't function properly in the context of a patient who develops cancer, that we've leveraged that knowledge to say, we can take patients' own T cells out of their bloodstream, collect them, take them to the laboratory, and modify them genetically to recognize the cancer, which they were failing to do. Expand them in the laboratory, take them back a couple of weeks later to the patient, and infuse them like a blood transfusion. They sweep through the body, and now the T cells are armed to go after these cancers. They attach to the cancers, they punch a hole in them, they release molecules that go in and chop up their DNA, molecules called nucleases. It's really quite remarkable, and it's revolutionizing important parts of cancer medicine. Non-Hodgkin's lymphomas now, multiple myeloma that you hear about from Dr. Abdullah, and now moving at our center as well as a number of other centers in the country in clinical trials into patients with solid tumors, breast cancer, colon cancer, pancreatic cancer. We have a number of such studies. However, this has come to the forefront such that it's not experimental for a number of diagnoses currently. It's FDA approved for patients with multiple myeloma most recently, and for a number of types of lymphomas, non-Hodgkin's lymphomas. And the differences that we've seen, 7% expected remissions before CAR T-cell in some lymphomas to 80% complete responses. You'll hear about multiple myeloma from Dr. Abdullah. Children and adults with acute lymphoblastic leukemia who have a 1-year survival of about 15% when they relapse. So the majority of patients will have died at that point, having 80 to 85% complete remissions, most of those durable long-term after the therapy. So this is a paradigm shift for cancers. There's a lot of work that needs to be done. It doesn't work for everyone. And for some patients for whom it works initially, it subsequently fails and they relapse. But we are seeing patients, for example, with lymphomas, 40% of patients alive without relapse at 4 years. That's very comforting and reassuring that this probably represents curative therapy for a substantial percentage of patients.
That's almost got to make you cry when you say it. That is so dramatic.
It's really remarkable. It's a remarkable time. It's the most exciting time in the history of cancer therapeutics, in my opinion.
Dr. Abdullah, tell us the story of multiple myeloma.
Well, I mean, majorly we have to talk about this myeloma like it's a blood cancer. Unfortunately, it's unique by the majority of these patients are not cured by, although we have multiple treatments. And as Dr. Mcgurk has been talking about, the CAR T-cell has become a major interest of treatment for myeloma due to the uniqueness of this treatment. The majority of the myeloma patients, relapse after multiple type of treatments that we use. And every time they relapse, there's a higher chance that they're not going to be able to go back to remission, a higher chance for increasing mortality rate. The specificity of this CAR T-cell actually played a big role in order to change that fact, So in several other studies, the FDA approved a lot of drugs in that particular patients that are refractory to many agents. The response rate was really dismal, about 20 to 30%, and they stay in remission for about 3 months. The majority of these patients have average to live about 4 to 5 months, unfortunately, up to 6 months. The CAR T-cell has changed that, that concept, with a higher rate of response rate, around 75%, which is impressive because we're not talking about multiple treatments. We're talking about only one infusion for these patients. The number of the percentage of patients who went to remission was around 33%, which is also very impressive for these patients. The average for these patients to stay in remission exceeds 9 months. For those patients who achieve complete remission was over 19 months. Overall, that is really actually interested for me actually at a beginning that we believe that this could be actually a pathway to cure myeloma, because we are trying to acknowledge the fact that there's other patients who did not respond to the treatment. Is it because they got multiple lines of therapy? Can we use this CAR T-cell a little bit earlier than later in relapsed myeloma? I think we are seeing like a great opportunity to actually, hopefully in the future, finding a cure for myeloma, especially for our myeloma patients.
If I may just comment here as well, we're just at the very beginning of this process. We've just been doing CAR T-cell therapy for several years, and we're already seeing unprecedented responses in myeloma, as Dr. Abdullah just described. And we've just started learning how to manipulate these cells in the laboratory. So there are men and women in laboratories throughout our nation, including in our own center, who are working on how to better what happens in those patients who don't respond, or those patients who respond and relapse. How does the T-cell behave in that circumstance? And let's modify it even more in the laboratory to be more effective. So what this is signaling to us is that we're going to have curative therapy for a significant percentage of patients for whom there was no such curative therapy previously.
Yeah, that is such a major statement, and congratulations for all you guys' great work in this field. And it's got to make you feel really good about the work you do. It's when I was on CF and this new drug came out, and all these patients felt like they were cured, 80 to 90% of patients just feeling so different and thinking I could have a normal life expectancy. To be able to say that to blood and marrow cancers, to say, better start thinking about retirement again. I mean, that's a pretty big statement, isn't it? It's got to feel good. It's got to really feel good. Jill, let's see which questions are out there from our community.
Got a lot of questions this morning. One of the questions I'm going to start with is you talked about, do people with blood cancers develop antibodies after being vaccinated? And they wanted to know if you'd go over that again, and should they even get the COVID shot if they're not very successful?
Yes, absolutely. They should get the vaccination because, as I mentioned, we're still in the early stages of understanding what kind of immune response these patients have. And it's not just the antibodies, by the way. There are cells, these T cells I've been talking about, and they're not as easy to measure. They are being measured in research laboratories, but they're not as easy to measure as the antibodies, but they're every bit as important as the antibodies. The antibodies are important to clear the virus, but T cells attack virally infected cells. So that what we call the T cell repertoire, the whole immune system and the B cells that make these antibodies are important to understand. How those come back after chemotherapy or after a stem cell transplant is well understood, and that helps us time our vaccinations to know, okay, this patient is recovered to the extent that we can probably count on getting a vaccination response. There's no downside in our population of patients to vaccination. Even for influenza, for example, early after stem cell transplant, majority of our patients will have a relatively minimal or low response rate, but 35-40% will have a protective response rate. And so we'll take 35% over 0%, and so we vaccinate those patients, and the same applies to COVID. We'll take whatever we can get in terms of protecting our patients. As I mentioned, we have patients from 23 years of age to 65 years of age who have died in the last several months in our transplant program in complete remission after a stem cell transplant. As we learn more, we'll be able to figure out with higher fidelity where and when we should vaccinate these patients. Right now, we have a blanket approach as to our colleagues across the nation that we vaccinate all of our patient population when their blood counts have recovered appropriately and not in proximity to the chemotherapy or at the same time as the chemotherapy, but perhaps a week or 2 or 3 weeks later. So we're having these discussions with all of our patients. It's an important issue, and the patients may well respond. We should try.
All right, here's a word problem. I had a confirmed case of COVID-19 on December 2nd. I received my first Pfizer vaccine on March 4. I was admitted to the hospital on March 7th with extensive diffuse emboli in both lungs and in my right ankle. I am on blood thinners. I'm scheduled for my second shot on Thursday. Should I get it?
Man, there's a lot that we don't know about that story, Hawkeye.
Yeah, I mean, that's a pretty intense, complex situation. I think you probably need to have discussions with your physicians. If you had significant amount of blood clots, as you say, there is a possibility that you also had consultation with hematology, the blood doctors while in the hospital. I would talk with them as well. I think there's just a lot of details that we don't know about. We certainly most of the time is going to say we would err on the side of safety and go ahead and give that vaccine overall for that durable response. With the amount of information available right now, I think in the complex story, probably just talk with your physicians about
And I would
that.
just say, COVID can cause thrombosis. We know that.
Exactly.
And even prolonged illness after, depending on your degree of disability, if you're not as mobile, that can cause blood clots. We know that. Pfizer vaccine and Moderna, to date that we know of, have
Correct.
not been associated with thrombosis, and that's been looked at pretty steadily and pretty heavily because of the stories around AstraZeneca and J&J. So I don't know that I want to ascribe it to Pfizer and Moderna, but we'll obviously continue to watch that. I think it's more likely it's a sequelae of potentially COVID or other underlying diseases this person may have, because lots of different diseases, Dr. Mcgurk, are associated with blood clots.
Absolutely, it certainly are. It's broad, it's complex, and the patient's clinical course, as Dr. Stites pointed out, may well have contributed to this entire event and be completely independent of the vaccination. I agree with Dr. Hawkinson that based on the information that we have so far, proceeding with the second dose is likely the prudent course of action. However, as Dr. Hawkinson pointed out, it's critically important that this patient go to their physician who knows them better than, extensively better than what we know right here and now. And that their primary physician may want to consult a hematologist to help address this question. We have a very robust, sophisticated hematology department here, and we see patients with such questions and concerns in clinical events like this.
And a delay of a week or 2 weeks, frankly, if you've already had COVID and you've had
point.
one shot, that second shot you can delay it a couple weeks and not be concerned. And Dr. Abdullah, just to say, I know in multiple myeloma and disorders similar, there are a lot of blood clots in those things as well. So we know how prevalent blood clots can be in other diseases.
Correct. Yeah, absolutely. And not only in active myeloma, also we have some of the drugs, unfortunately, that commonly we use in these patients increase risk of the clotting, like Revlimid and pomalidomide or Pomalyst. So we do have that share of patients that, possible they can develop clots. However, I have a lot of myeloma patients who got the vaccine and they're on these treatment. I did not see any case, specifically I'm talking about Pfizer and Moderna, but I did not see any cases of a new clot that developed while they're on this treatment.
Yeah, great point. Thank you.
My husband has factor V and is worried about the vaccine. What are your thoughts? What's factor
Okay.
V?
All right, let's talk about that. Dr.
Yeah.
Abdullah, can you tell us a little bit about factor V Leiden deficiency and whether or not somebody should be vaccinated?
So
Yes, they
that's a great
should.
question. I mean, I think the factor V Leiden, it's a mutation that happened, unfortunately, increase the risk of clotting for these particular patients. And the question is this a homogeneous or heterozygous for these patients? Because if they're heterozygous, they're less likely to develop any clots. I think there's always that concern. I have patients who got the COVID-19 and they have the factor V mutation and they didn't have any of these clots. So I would just suggest, to kind of like make sure that what type of factor V mutation that they have. And if it's like a heterozygous, I think their risk is really low to develop a clot. If they're homozygous, I think there's a question if they have any clot in the past, but I think it's still safe to have the vaccine for these patients.
And again, I'll just come back to having them discuss this with their hematologist. This patient probably already has a hematologist who is counseling them regarding their factor V Leiden mutation, and it's important that they discuss this with their physician.
And Hawkeye, what we don't want to do is have people start looking at this issue of clots and saying, I don't want to
Yeah.
get a vaccine, it's too risky.
Yeah.
What's too risky is COVID-19.
Yeah, and I think, again, to your point as well, the mRNA vaccines, we haven't seen any signals of that. Certainly, I think we've seen some low platelets, but none of the clotting issues as well. And we know the dangers of getting COVID-19 and what that can do. Even to otherwise healthy people, they can get blood clots like that. They can get severe disease. They can get the long hauler. So all of those things are much worse than the risks of the vaccines, especially what we have seen from the safety profile of the mRNA vaccine.
And even in children now with the risk of stroke and mental status
Yeah.
changes and encephalopathy or dementia, even with,
Yep.
not dementia, that's not the right word, but other neurological effects as a result of the
Yeah.
inflammatory syndrome. You want to get vaccinated as soon as you're able. Jill.
Kitty's 33. She had the J&J vaccine 5 weeks ago. Ross doesn't say his age. He had the J&J shot 10 days ago. They want to know if they should be getting blood draws to check for clots, and are they at risk?
Oh, those are great questions.
Yeah.
Let's take that on.
Real-world
We're going to
questions.
ask our whole panel this one because it's the hot button question of the morning. So, Hawkeye, what do you think?
Yeah, again, I'm not going to say that I don't think you need to go and just get random blood draws to look at your platelets. I would continue to monitor for those symptoms. I don't know that we have really seen any of the venous thrombosis, any of this blood clotting, more than 3 weeks out from the vaccination. So I think you're pretty well safe. It's not a 100% again because we don't know the full details yet. They haven't been released to us. But just continue to monitor for symptoms. Again, blood clots, typically we would tell you to monitor for pain in your legs or swelling in your legs for lower vein blood clots. For blood clots in your lungs, it would be shortness of breath, chest pain, more difficulty breathing. We haven't really seen that with this vaccine, and more what we see is the sinus venous thrombosis. So things you'll be looking for, increased sinus pain from your normal. I have a friend who has significant allergies, so she always has some sinus discomfort. But increased sinus pain or pressure, increased headache, things of that nature. And then that could be a signal to go get an evaluation, especially if you're 3 weeks or less from that vaccine. But just going out and getting random blood draws, I would not. And then as far as the gentleman that asked the question, again, for the most part, what we know, we've really seen it mostly in females in that 18 to 50-year-old range. So your risk is probably reduced, but without knowing any other details of the FDA investigation, the CDC investigation into all the details of the blood clots, that's what I would say to monitor, is really just monitor for those symptoms.
And I would just offer that, remember, it's 1 in a million. And even if it's 3 times that, it's 3 in a million, which is so much safer than your blood pressure medicine, your antibiotics. I mean, you just got to put it into context, people. These are really safe, even if there's some complications. We have hyper scrutiny on it, but the reality, far safer than many drugs we take, Joe.
Yes, absolutely, without question. That's exactly right on the mark. And I agree with Dr. Hawkinson. Routine surveillance of blood testing really makes no sense. It would be an extraordinary effort with minimal to no yield for the overwhelming majority of patients, if not all of them. I think clinical symptoms should be the driver. If you have concerns about any clinical symptoms after any of the vaccinations that are available, you should contact your physician promptly.
And Dr. Abdullah, from your standpoint, no reason to not get the J&J vaccine. I assume at this point you'd still say yes if that's one that's offered, go get it.
Yeah, I will really agree about that. And again, let's look at the facts about unfortunately, we have this rare type of blood cancer, blood clots, you know, and we would like a lot of people to understand this is not something, this cerebral venous sinus thrombosis is not something new from the vaccine. We see it in rare cases in pregnant ladies, people who are on oral contraceptive pills, other coagulation disorders. So we see that it's very rare, and the cases, I think it's 6 out of 6 million from the vaccine. So it's very rare to see these cases. I think we just have to kind of like make sure there's more studies in order to see what other risk factors these patients who develop this. So I'm encouraging, like, hopefully that, you know, the vaccine will be resumed in the future, and also other vaccines like we have Moderna and Pfizer that proven it's safe, you know, to get it. As you all say, you know, it really helped in terms of the real world to decrease the risk of hospitalizations, the severe infection, and also the rate of mortality rate.
Last question.
Yes, ma'am.
Adrienne wants to know, I donate platelets and I'm fully vaccinated. Normally my platelet count is around 230. Last time it was 173 after vaccination. Could that be because of my vaccine? I don't even know what a normal platelet is.
That's a perfectly normal platelet count, and I would have absolutely no concern about that platelet count.
Yeah, my normal platelet count, and I've even talked to this guy about it, is around 120 or 110, and I didn't go checking on it after the vaccine, so I think it probably came back. So I wouldn't be concerned about that.
And we expect variance in platelet count from day to day, actually. And if you measure the platelet count a couple of times a day, you would see some variation. So this is a absolutely normal variation in a normal platelet count.
Great.
Hey, tomorrow we have the founder of the COVID Care Force. Dr. Gary Morse is here with us. He created the Care Force 1 year ago to bring volunteer doctors and nurses together to care for vulnerable populations. He has a remarkable story to share about his experience with the Navajo and Chickasaw nations in particular and what we can learn from them. That'll be a really great program. Looking forward to that. Let's have final thoughts. First, Dr. Abdullah, final thoughts for the day.
Well, you know, just kind of like the excitement news about the CAR T-cell, you know, for all our myeloma patients, that we think it is going to be a really great revolution for that. All blood cancer patients, specifically the myeloma patients, we highly recommend them to get the vaccine as soon as possible. Communicate with their doctors, especially if they're on treatment, so they can actually have, better adjustment and better delay of the treatment in order to get the vaccine. And as we talked about, if they have any possibility of underlying medical conditions, or they have any possibility of inherited coagulation disorders, you know, to talk to their hematologist if they're a little bit worried about getting the vaccine, so they can have better insight about the importance of getting the vaccine and the risk and benefit of that.
Absolutely. Joe Mcgurk.
It's an extraordinary time in cancer therapeutics. I'm going to put a plug in for CAR T-cell therapy. We have 23 active clinical trials at University of Kansas Medical Center currently, including in solid tumors. We will have a conference this coming Saturday, provide information online about upcoming CAR T-cell therapy advances, current indications, and stem cell transplantation, and you're all welcome to attend. Get your vaccination for goodness sakes.
Dr. Hawk?
I can't follow that. I don't endorse all that. You know, we know the safety. We'll wait for the Johnson & Johnson update, but other than that, you heard it from Dr. Mcgurk and Dr. Abdullah. These are our experts. Even in their complex populations with significant blood and bone marrow disorders, it's safe for them as well. We need everybody who is able in those vaccine groups to go get vaccinated. We see a continued increased rise around the nation and in our community, and so to protect our community, we need to continue to get vaccinated. And we have plenty of slots open for vaccination here at the health system. You can either go to MyChart if you're a patient, or you can go to kansashealthsystem.com//vaccine, or if you don't have a computer, please call 913-588-1227 to get set up for those vaccines.
All right, I want to thank our great guest this morning. What a terrific discussion. And I wanted to invite you to reflect a little bit about what you heard today, because what you heard is about cures for cancer, for leukemia, lymphoma, multiple myeloma. Those are messages that it is a privilege to be able to both hear and bring. Having been in medicine for 31 years, I've watched a lot of patients die, and friends and relatives and family members from this type of a scourge. But science has brought us to a point where we can cure multiple myeloma and leukemia. That makes me want to cry. It's just so amazing. When I said that earlier, it's like these new drugs in CF, to be able to look at your patients and say, start thinking about retirement. That's impressive, right? That's a game changer. And you know what? Trust the science, people. Vaccination has come to us from science, just as CAR T therapy has. Grow old along with me. The best of life is yet to be, the last of life for which the first was made. Do not throw away your shot. We'll see you tomorrow.